Dr. ANAGHA. She is a very prolific surgeon from Mumbai itself, a local chap over here, and then she is member ARC, so she is a big shot in AIOC. All of us must salute her, and we often see her videos and live surgeries and what not she does. And she is medical director of, I think, the latest and most equipped eye hospital in Mumbai, Anil Eye Hospital. So we are fortunate to have her here. I welcome you, ma'am.
Thank you so much, Dr. Mohit, for including me in your IC and for such a lovely introduction. A very good afternoon to all of you, and on behalf of the LOC, I hope all of you all have had a very good time in the conference and have had a comfortable stay in Mumbai. So I hope this becomes a very memorable conference for all of us. So this is a very unique IC, and I compliment Dr. Mohit for choosing such a topic. And today we are going to discuss a lot of angles and a lot of parameters, how we can go wrong and what we need to do to correct our mistakes. So yes, now we come to the second topic, and that is an unhappy patient and due to some kind of biometry errors. So we all know that a pre-operative assessment, I cannot overemphasize the fact that it has to be precise, accurate, and yes, we have to hit emetropia. But there can be problems in keratometry, there can be problems in the biometry of the A scan, axial length, or the IOL formula. A lot of errors are correctable, and all of them have to be prevented at all costs. So you can have not only the measurement errors, but also manual biometry errors, whether it's just a mislabeled IOL or the transposition errors. And yes, we will also touch upon special situations where you can have problems and you need to take extra care. So let's see a few case examples. Case 1, a 55-year-old female, history of arthritis. She was operated 1 year ago elsewhere, and she was very unhappy with the earlier surgery. And now she came to us for the left eye cataract evaluation and workup. Now, if you see the IOL master reading, that it shows a cylinder of 2.78 at almost 100 degrees. Now, we did for all our toric patients where we are planning a toric, we also do a topography. Now, if you see the topography of this patient, you can see there are a lot of dry spots. And if you see the astigmatism on topography, it's 1.64. And if you compare it with the IOL master, it's 2.78. So definitely there is a lot of disparity between and discrepancy between the two measurements. The patient complained of arthritis, so definitely this shows a poor ocular surface. We put a lubricating drop, and after some time when we repeated the biometry and the topography, you can see now they are correlating. So it was 2.14 at 96 degrees on IOL master and 2.17 on the topography. So this is extremely important. I would go ahead and say in today's day of using masks and so many other problems like excessive exposure to digital devices, every patient you should consider as a potential patient of dry eye. So all these patients, especially if you are planning premium IOLs like torics or multifocals, you have to do a topography in these patients and also look at their ocular surface. Now this was another patient, a 65-year-old male who came for a toric IOL workup. Now usually we need to check keratometry on at least 2 or 3 instruments and see whether they correlate or not. You cannot just do an auto K or a manual K and then just stop at that. And ideally we always repeat it on another day, or if not possible at least on the same day, but you have to repeat and see whether they are repeatable or not. Now here if you see, you can see that there's a wide range of keratometry right from 0.73 to 1.75. So this is not acceptable. Again, the reason here was the patient was a chronic diabetic and the T-BUT was just 4 seconds. So no matter what the patient is, and look at the topography also, so it shows irregularity. So you should not overlook any kind of discrepancy between instruments. While doing biometry, be very careful, no dilatation, no applanation to be done before biometry, and also ask for history of contact lenses. So if there is a disagreement of more than 10 degrees or I would go to the extent of say even 5 degrees between two instruments, please repeat, use lubricants, and because we all know that even a 10-degree misalignment will cause a loss of 30% of the toricity effect, and that is why you need to be wary of these patients. Now let's look at another case, a 55-year-old patient, high myope, cataract surgery, operated elsewhere, came to us for a second opinion. It was 2 weeks post-op and she had a refractive surprise of +5 diopters. Now, when we went through the papers, there was an IOL power that used was 5 diopters, but the actual power was 10 diopters on optical biometry. So in high myopia, the most important problem is the posterior staphyloma. So the deepest portion of the staphyloma may be located eccentric to the macula, and the measurement may be longer than the true axial length, which is along the visual axis. So here you may not get a distinct high retinal spike, and it can cause a significant error. So I would always recommend an optical biometry, especially an IOL Master 700, because you can see, you use the fixation target and you can see whether the fixation is right or not. And always in these cases, it's a good idea to correlate with the B scan. Even if you're using an immersion, you can use probes with the fixation light, and that always makes a difference. And please instruct the patient to look, otherwise you can go really haywire. Also use appropriate formula, which we would be alluding to later, and try to aim for a slight myopic post-op refraction. Now, even if you're using an optical biometry, choice of the IOL formula is so important. Now compare the two these things on your screen. The one on the left, you can see the axial length is 32.17 millimeters, so it's a very high myope. And the Barrett Universal 2 shows a -0.5, whereas the SRKT shows a -2. So you can really go haywire in these cases. At the other extreme, you have a high hypermetropia patient. Again, 20.38 is the axial length. You look at the Barrett Universal 2, it shows a +33 diopters, whereas the SRKT shows the +31.5. So you can really go haywire, and these are things which you really need to be very careful about. Again, if you are having problems like a retinal detachment or a macular edema, a very dense cataract, you may end up having a shortened axial length measurement and a surprise post-op. Especially those people who are using contact method, you have to be extremely careful. I think in today's day and age, you should avoid doing contact method. One of the biggest problems is the error which is caused by corneal compression. So friends, even if it's just 1 millimeter error, the shorter the eye, the greater would be the error. Like for example, 1 millimeter error can cause a 3.75 diopter problem in a short eye. So this is absolutely unacceptable. There are so many other reasons also. Even if it's a gain setting, the error can occur if the gain is set too high or too low. So in case of these measurements, you can have an incorrectly short measurement. Also, if the sound velocity used is too slow, or if there is a misalignment of the sound beam. At the same time, you can have an incorrectly long measurement due to an air bubble, or if there is a fluid bridge, or again a posterior staphyloma. Now, not that optical biometry is without any errors. You have to have a correct alignment and a correct fixation. We all know that there is an automated method also, but if you go on to the manual, you can still go wrong. So look for correct fixation. For example, the foveal fixation, you can also have a tilted lens. Now for example, here you have an example where there's a normal centered A scan. You should look at all the telecentric Myers, whether they are central, whether they are crisp or not, and the central line that's going from the cornea to the fovea. For example, if you're looking at the Hoya Vivinex, you can see it shows a 21.5 diopters as the IOL power here, and the astigmatism was 1.33 at 167 degrees. Now this was a patient where the same patient where we're not fixating properly. You can see that the telecentric Myers are also not central. And here now the IOL power is 22.5 with a 2.42 astigmatism. So you can actually cause a error. Now inadequate patient fixation could be due to low vision, nystagmus, or even strabismus. What you need to look at all those green ticks that you can see. So unless and until those green ticks are there, it means that your biometry is not perfect. Now for example, here you have a case, the IOL master will actually give you the alerts, like if the fixation check is right or wrong, if the axial values, length values are not consistent, or if it's too short, or if it's a too steep cornea. Now here for example, you also look at the IX and the IY, which is the chord mu. So you know whether it's a higher angle kappa or not. So here you can see it's a 1.4 millimeters and astigmatism of 0.76 and the IOL power showing 23.5. Now if it's slightly better, you can see now that it's changed from 1.4, the IX has changed from 1.4 to 0.9, and the astigmatism has now changed from 0.74 to 0.95, and the IOL power from 20 now to 22. So that only means that even in an automated or even in an optical biometry, you have to be careful. Now, this was another patient, residual astigmatism post-toric IOL. Now, what is important is not just the fixation, but also the position of the head. Now, if it's a tilted position like this, you would get an astigmatism of say 1.56 at 83 degrees, and with the correct position at 1.48 at 105 degrees, you're already off by 30 degrees. So you have to be very, very careful. Another case, a chronic diabetic stable PDR with silicone oil post cataract surgery surprise. Now you have to actually check whether the vitreous body has been mentioned as silicone oil or not. On your left you can see a Barrett Universal 2 giving you a 22.5, whereas actually it is 25.5. So all these make a difference. In eyes with silicone oil, remember there is a low sound velocity which can cause pronounced sound attenuation and difficulty in identifying the spikes, and that is why this is less affected in optical biometry. There is a lower refractive index than the vitreous. The last case, this was a myopic LASIK patient done 10 years ago, diabetic since 8 years, came to us post-op refractive surprise of +3 diopters. Now look at the topography and also look at the corneal wavefront. You can see that there is a vertical coma of 1.2, and you can see that it's a decentered ablation. Again, when you're doing an optical biometer, you see the lens, it's shown as phakic but LVC untreated. Check what mode has been done, because most of the time it's the technician who is doing it. The technician may overlook the fact that the patient is a post-refractive surgery patient and may go on to do a routine case. So if it is LVC untreated, look at what the SRKT shows. It shows a 9 diopters. Now, you should also go ahead and do with multiple formulas. So this is an ARCRS online calculator. It shows an average IOL power of almost 12 diopters. So your 3 diopters is gone there. Okay, even if you use the Haigis suite and you have an LVC mode of LASIK, you get a 12 diopters, which means it's correlating. You use a Barrett suite and a Barrett True K, not the Universal 2. Use the True K in these cases, you get 12.5. So which only means that they all correlate. So you have to do them and then check. In cases of post-LASIK, you can have errors not only due to a wrong keratometric reading, but also you know that the back to front ratio has changed, and you should use the other figures also. I would just run through this. Just one point I would like to say, that if there is a decentered ablation, even these new formulae will not work. There has been a paper by Dr. Savini which says that in these decentered ablations, you should do the aphakic refraction method, which will definitely work. So this was what I wanted to say. And just a small tip just before we leave. In case you have a patient, so take good history of refractive surgery or vitrectomy or contact lenses. Ensure regular calibration of your equipment. Check both eyes. Repeat whenever in doubt. Use an IOL formula depending on the axial length. Repeat the keratometry if there is less than 40 or more than 47. If there is a difference between the two eyes or poor correlation with refractive error. Repeat biometry if the axial length is less than 22, more than 26. Difference between the two eyes of more than 0.3 millimeters on prior keratorefractive surgery. Personalize the lens constants and reduce manual errors. So thank you so much for your kind attention. Thank you.
Thank you, Dr. ANAGHA. Very valid and important points highlighted by ma'am.